I'm not going to go a ton into like here are the most common causes of death piece of this. That's in your book and you can look it up in your module. I'm not worried about it. But for right now, I want to talk a little bit about what we learn from those causes of death. So when we talk about causes of death, one of the things that you'll recognize very quickly is that different people are affected by them differently. This sort of changes over time. This changes by gender. This changes by age. There's all of those kinds of distinctions, and you'll see them in your textbook and in your module. All of that is really, really common. What I want you to know from that is that in some ways, those distinctions tell us a lot about the need to study health and illness and medical sort of experiences sociologically. Partially because the fact that people experience sort of health challenges in different ways based on gender, other sort of forms of socioeconomic status, that kind of thing, tells us that the factors that we're looking at are not strictly biological. Not that there's no biological cause, but they're sort of beyond that. So, for example, when we talk about different causes of death between men and women, a lot of those point back to experiences of socialization. So, for example, it's more common for men to be diagnosed with heart disease. And when we look at the sort of medical literature, you find that heart disease is in a lot of ways linked to diet. And even if you compare people at the same socioeconomic status, and we'll talk about sort of socioeconomic status and health later on, but even when you compare people with the same socioeconomic status, women are less likely to have heart disease than men are. And that has a lot to do with things like gender socialization, in that in a lot of ways it is more accepted for women to order a salad, and it is sort of expected for them to eat the vegetables that are likely to prevent heart disease, whereas men have sort of a more socialization that leads them to consuming, for example, more meat, more fast food, that kind of thing, which means that the biological outcome of something like heart disease has social roots and social origins, okay? And essentially, when we look at it from that perspective, most causes of death and or illness are social at some level. Even when we can identify sort of biological causes, right, like an infectious disease. Okay, but there are still social factors in that. So, for example, when we look, we're in the part of a pandemic. I don't want to say that we're quite at the end. That's a whole big thing, but we're experiencing a pandemic right now. And if you look at the early pandemic sort of experience, one of the things that was happening was that we were seeing a lot of cases of COVID in assisted living and sort of homes for the elderly. And that's not necessarily because the elderly that is not entirely because the elderly are more vulnerable to something like COVID. It's also because of the ways that socially those environments were structured, right? And that there was a single care worker who went from room to room, which creates a vector to transmit that illness in that context. Those facilities were often understaffed, which means that staff did not have the resources available to do things like change the mask, change their gloves, wash their hands, do all of that stuff between seeing different residents. And that created sort of larger forms of transmission in that sort of space. So when we talk about this sort of thing, it's really important to understand that pretty much all of our experiences of medical illness are social in some ways. So, for example, when we talk about things like waterborne illness or water quality or things that happen from the conditions that exist from poor quality drinking water, the idea of poor quality drinking water is connected to investments in infrastructure and where people are wealthy enough, for example, to insist that their drinking water be clean and accessible and that kind of thing. So there's a lot of ways that we can look at that. I want to sort of talk a little bit about some of the ways that piece can get interpreted. So when we start looking at a lot of social relationships and a lot of the sort of causes of illness, right? Your book talks about things like diet and exercise and sort of managing stress and that kind of thing. Those are really, really important, but it's also important to understand that they occur in a context. So when we talk about that, one of the things that we're saying as sociologists is often that we need to be very careful about not assigning individual responsibilities to things that are more accurately anchored in the macro social environment. So, for example, it's ineffective to tell people to just eat more vegetables or just go for a run. Because that sounds as though if you don't do those things, if you don't go for a run, if you don't eat vegetables, if you sort of aren't eating right exercise and getting enough sleep, whatever that sort of particular marker of health we're looking at is, that it's your fault. And that very much doesn't account for the sort of structural barriers that can exist for people. So if we sort of say, well, everyone should be able to exercise, it's really easy to just go out for a run. Okay, that's less expensive, for example, than taking up fencing, I guess, which for those, or like any number of sort of competitive sports that require a lot of expensive equipment. However, to go out for a run, you need to be able to afford shoes, which is sort of like a direct cost associated with that. But you also need to recognize that structurally, some neighborhoods are safe to run in and some neighborhoods aren't. And some people are better able to run than others. So, for example, when we talk about sexuality and gender, which we did a couple of units ago, when we do that, you have to recognize that like women are at more risk of things like sexual assault if they go out for a run by themselves, and that is sort of that intersects with our conversations about race and ethnicity, and that some people are more likely to be victimized and less likely to feel welcome in spaces, and all of those things contribute to whether or not an individual person is likely to get enough exercise according to sort of like medical doctors. So that's part of it. And we could do the same kind of discussion about eating healthier, which presumes, as your book sort of talks about, conversations about access, right? Is it appropriate to tell someone, well, you have to eat healthier if it's going to take them an hour and a half to go get groceries? Because that's how long it takes. Like, it takes an hour and a half to get to the nearest grocery store that sells fruits and vegetables on public transit, and then an hour and a half to get home. And is that reasonable for someone who is working however many hours in order to survive? So there's all of these kinds of conversations that are a part of this. So that's a sort of brief statement that when we look at them in this way, almost all of our causes and of sort of death and morbidity have social elements to them, which is not to say they have no biological elements, that they don't have any sort of thing to do with what like the physiology of the body. Just to remember that in a lot of ways, the physiology of the body is shaped as well by social environments.